Thank you for joining. Um, Today we're doing something we haven't done before here at Flexpa, which is a launch week rewind. We had a launch week a couple of weeks ago, and we launched 5 new features or products or things that we're doing basically. And we wanted to give a chance to folks in the healthcare interoperability space and patient access in our customer base um, uh, to recap it with us. So we're going to rewind. We're going to go through each of the announcements to ask questions that you might have had. So I'm joined today by Angela and Hannah. And we're really happy to answer anything you might really want to know about what we're going to cover. So I'll bring this slide back up really quickly just to give an overview of today. We are primarily going to focus on 4 of the 5 announcements. We are going to show all 5, but we're going to prioritize and give more time to 4 of them. The first is FlexPal, our new patient agent. We're going to talk about TEFCA IAS, or Individual Access Services, and our announcement that we've become a provider, an IAS provider. We are going to talk about multi-network consent because we have evolved our patient access model towards being multi-network. That's exciting. And we're also going to talk about our support for smart health links. Before we dig into that, though, we do have a quick video that is the sort of summary of all of that in 2.5 minutes. So if you watch the video, feel free to drop off after, I guess, but please stay on if you want to ask us questions as we dig into each one. Okay, so a couple of housekeeping things just before we dig into this. Please use the Q&A functionality. We will generally be taking an interrupt us approach here. I think maybe even Hannah was going to interrupt me earlier. So she will do that, and we will answer questions mostly in an interrupted style as sort of a live Q&A as we get through things. I do see a couple. Hannah, what do we got so far?
Yeah, so the first, just an admin question, is if a recording will be posted of the webinar afterwards.
Yes, so we will post this publicly. So if you don't want your name associated with a question, for example, please don't post one with your name. You can submit one anonymously. And any other participation that you do, please be aware that we will be making this public. And we'll be happy to share it with everyone.
And the second question is about FlexPal and if it can be white labeled for the patient experience or it will always say Flexpa.
Yeah, it's sort of a complex question. If you're familiar with what we've done to date, then I would say the part of that demo that doesn't have to say Flexpa is really the end part. So if you're trying to build an agentic patient-facing experience, we can definitely help you. So we've done it ourselves, we've done it for other folks, and we'd love to do it for you too. In that case, once the records are in an application, of course that application is, can be branded however you'd like. The important parts for Flexpa though are that consent process, and we're an integral important part of that. We will not, you know, uh, allow an integration where we're somehow hidden from the patient. So, really core to what we do is being completely transparent and open about the transfer of data. We help people do that. We help everyday people, everyday patients share their data with whomever they'd like to for whatever reason they'd like to, because it is their data. But we won't, sort of hide that at any point. We're always in the loop. So with that, we are going to go back to the first demo, which is the patient agent that you saw. Um, and I'll share the slide again, but I'm going to quickly jump into a live demo as well. What is this? What is FlexPal, our patient agent? We've been really excited about the new opportunities for direct patient applications and patient empowering applications to exist. And we've seen this wave of AI and LLMs really impact the provider side of the equation here. So we see, scribe, AI scribe companies. We see companies like Open Evidence really provide rich uh, AI tooling to physicians in a way that now it's totally normal, totally natural. And we really see an opportunity on the patient side of things to empower patients in different but similar ways. Similar in that we think that there's a big opportunity with agents. And I'll define agent in a second here because I think it's misdefined a lot. But also in providing them directly to patients in a way that is patient empowering. So let's get into the demo. First, what do I mean by agent? Really misused term a lot. An agent is a tool call in a loop. Okay, what's a tool call? Well, over the last couple of years, we've seen lots of different experiments where we will, through techniques like prompt engineering or RAG, retrieval augmented generation, we'll build sort of complex pipelines around an LLM to give it some data at the time that we're prompting it. And that has really well-known limitations, of course, the context window size being the biggest one. We only have so much data that we can provide to the LLM at inference time, at the time that we're prompting it. And over more recently, and especially in the developer space, the developer and software development space has become really comfortable with a more agentic workflow or agentic search, which means that instead of providing the LLM directly, a patient's entire health record, what we do instead is provide the LLM with tools that it can use to navigate those records depending on the circumstance. So I am going to show a live demo of this. So hopefully the weather is good for live demos because you never know. So here we go. So this is running on my phone. I'll get a thumbs up if we can see this. Yes, thank you, thank you, Angela. So once a patient has gone through one of our networks, so maybe they've used the TEFCA IES flow that we're going to talk about in a few minutes, or maybe they've used a traditional patient access flow, a smart on fire flow, an OAuth flow. Regardless, They enter our application, they enter FlexPal, and we have synced their records locally to this device. So all of the records are living on my phone here at this point. They're stored in SQLite database, if you happen to know what that is. If not, don't worry about it. Just know that they're on the phone. And I can ask questions about my, in this case, in this demonstration, about my claims history. So about questions that I might have for my health insurance, for example. And I can do really basic ones, right? So I can retrieve my coverage details. And the first thing we see there, it's going to quickly spit out the answer. But the first thing we see is not the answer, actually. It's at the very top. It says found one coverage record. And so what's happening behind the scenes here is instead of just, again, assembling all of the possible records and using up all of the context window to ask a question to the LLM, instead, we're asking the question and providing it with a list of tools. And in this case, we provide a tool for it to find the coverage resource, the fire coverage resource from the SQLite database if we happen to have one on the device. So if Flexpa has been able to successfully retrieve that record, then the LLM can take a look at it. And that's what it's chosen to do. So we highlight that in the UI here, found one coverage record. You might see this in other conversational AI applications where there might be a citation or some example of tool use. And again, for a software developer over the last year, chances are you've seen something like this or you've worked with an agentic flow like this. And then, of course, we get the answer. Okay, so not maybe that interesting or that impressive because it's really just spinning out whatever is in the coverage resource here. So let's do something more broad with summarize my health history. So it very rapidly, and I know that looks like how could it be that fast? But again, the data is local here. It very rapidly identified a patient resource, retrieved the patient information, found a coverage record, and it also wanted to do some claims analysis. So it wanted to retrieve the claims and ask some questions about them and wanted to query them, basically. And it has summarized us here as John Doe. This is originally sample patient data from Elevance or Anthem, the health insurance company. And it summarizes my copay, co-insurance deductible. I'm on a platinum PPO, and it provides me a nice summary of my health. I've had comprehensive lab work back in June. I did have an inpatient hospital stay in early December 2024. But I thought I had a vitamin deficiency. So it went back and searched some records, some claims records. We saw that happen, and it found that the lab work in 2024 did find a vitamin B12 deficiency. Um, who diagnosed that? Oh, is that Rachel Cohen? Okay. Additionally, Maria Gonzalez processed those lab results. Now, in this case, Rachel Cohen is a fake synthetic doctor here. It's not a real, not intended to represent a real person, but we could ask, this is a little more ambitious because of that. Is there a phone number you can find for Dr. Cohen? Doesn't have a record. Says let's call insurance. Okay, fine. What's Anthem's number? And we can give it a hint. Search if you need to, because it can search. And it gives us the Anthem customer service number. And when it's done a search, so when it's sourced information from public sources, they'll be cited there, just like similar applications. ChatGPT, of course, does this. That in itself is nothing special, but we've integrated a direct sort of health records conversation experience using records that we've obtained through our consent process and our patient access connectivity to deliver an agentic workflow for a patient in ways that we think are really similar to the kinds of experiences that providers and physicians are starting to be able to have. And I just really am this profound believer. I'm a true believer in the impact that this kind of empowerment can have on patients. So that's FlexPal. If you want to get a build of exactly what I just showed you, you can go to flexpa.com/app. We'll put it up on the screen at the end. We do have a wait list. It's in test flight, so you have to be an iOS user right now, but an Android version is going to follow soon. And we are beginning to test this publicly. So that
Quick,
is the first demo. Yes.
quick question. Is searching done from the records or from online? So I think you slightly went
So
over that.
the agent, I did go over a little bit. I want to add one thing, which is that you saw me give it the hint at the end there to do the search. So the search is available, but it's biasing its answers to the records that are available, and we can hint or instruct it to be explicit in that way. We're working through improvements that we can make to cite the included sources on the health record side. So we show the tool usage, so we indicate to the patient, yeah, we're really looking at your records. So when that animation happens, that's not just Flexpa putting in some UI there. We are showing what the agent is actually doing in, as we're processing this conversation with the LLM. So we are explicitly showing that, yep, we're going and retrieving records.
So follow up, maybe I missed it, but it looked like it was just pulling information from claims data and not patient records via TEFCA OAuth.
Yeah, I mentioned this super briefly, but easy to miss. I mentioned that we base this on our existing payer patient access API consent flow, but what we've done, and this sort of leads nicely maybe into the next sort of two demos, is we have broadened our network. So we've gone from a one patient access API network. You've probably heard us talk about payers before. If you know what we do, we broadened that to 3 networks, including TEFCA, which we're going to talk about immediately next. And so I'll leave that there. The only other thing I want to sort of answer on that question is from an API level, like, okay, we've increased the network. Well, how would that work in that demo? In this example, it's actually the same, because at the end of all of our network is a FHIR interface. And essentially what the agent is doing is just being given tools to interact with FHIR resources locally on the device. So any FHIR resource as a sink for Flexpa, so wherever patient records we get from anywhere we can get them, FHIR is the sink. It's the final format. And what we've done is created these small functions that the agent can call to interact with the FHIR records. So even though we've shown a sort of insurance-focused example here, that's not a limitation of the approach.
Another follow-up, will Flexpa customers get FlexPal as part of their subscription, or is this a different product and cost?
Depends on when you became a customer. So some of our earliest customers that we love working with, including customers like Budgie Health, they have a different bespoke arrangement than the pricing you can publicly find on our website right now. So there is a little bit. It depends when you became a partner to us, but the agent is not sold as a standalone product. It's just part of what we can rapidly build for you in a forward deployed setting. And forward deployed is what we do by default now. So if you're a current customer of ours and you need in your app to do that agentic example or build on it, like, please just tell us. We would love to help you. We'd love to help you build it. And one of the motivations for us in building FlexPal has been that we wanted to show in public that it's possible to build these health record conversations. And you can use the records that you obtain from us, the hard, like we do the hard work of the consent process and the network connectivity, the normalization at the end, and obsess over the details of Fire as a spec and go to all of the working group meetings that people don't want to go to. Like we do all that stuff. We care about that. It's the hard work. But at the end, you can build an agentic experience on top of open source public tools that we will guide you through. So that is not intended to be a new subscription. There's no new cost for that part of what we offer. Uh, Helping you build agents with records is core to our offering. So with that, I will pass it to Angela.
All right, so great segue over to TEFCA IAS. So I'll share my screen. Get a quick thumbs up from the team if you can see it. Not yet? Okay, great. All right, so the demo previously with FlexPal agent showed our bread and butter sort of claims-based pair APIs flow. The latest source that we've added to our platform here is through TEFCA IAS by being a provider. Quick overview here in case anyone listening is not as familiar with TEFCA. TEFCA stands for, oh, I hate undoing acronyms, Trusted Exchange Framework and Common Agreement. And how you can think about it is, nice, I'm getting claps, so I did that correctly. How you can think about it is like a network of networks, of traditional networks, with a regulatory and sort of governing body to determine how things are exchanged, perhaps the standards that they're exchanged by, and who is approved to be part of this network and who can communicate on the network. You might be familiar with traditional networks like health information exchanges or health information networks, your health gorillas, etc., Commonwealth. What TEFCA brings to light is this new access pathway called individual access services. So you can access the existing HINs and HIEs if you typically have treatment purpose. So you have, a provider with an MPI somewhere in your payroll, and you're, able to use that to access patient data. Individual access is sort of exactly as it's named, which means any patient can individually consent for their records to be shared to an application that may not necessarily have treatment purpose of use. And Flexpa sits sort of here as the IAS provider to help patients access the network and share their data. Now, we've sort of taken a multiplexing approach to becoming part of TEFCA and accessing the TEFCA network. And what we mean by that is, in order to access TEFCA, you must do so through a credentialed identity access provider. So the level of credentialing here is IAL2 and AAL2, just a bit of a mouthful, but there's a set of CSPs who have been credentialed at this level, and we have partnered with 2 of them. So that's Clear and ID.me, who this group is probably familiar with. And once you have a CSP, you have a patient go through this identity verification process, then you can use the token generated at the end to then query a network. And you have to do so through a QHIN. We won't go through too much of the nitty-gritty here, I think, on TEFCA hierarchy, but Flexpa has successfully onboarded with 2 QHINs, so Commonwealth and No2. Like the diagram shows here, all of that sort of funnels into Flexpa. We manage, which CSP a patient goes through and which QHIN we query. But at the end of that, we also support multiple standards for how the data is actually shared at the end. So you might be thinking, okay, why did they do this? Why have the multiplex concept here? Actually, let me go back here. On the left side here, why did we partner with multiple identity services? This is for a patient experience. So we want those who might be familiar with Clear already and might be familiar with ID.me already to be able to pick the brand that they're familiar with. In identity and healthcare, identity management, branding is very important. I see Hannah came off mute, so I'm going to finish the sentence and we can go to the question. And if a patient already has an account with one of these two IDPs, then all the better because they will shorten the registration flow. They can go through the account that they have already, potentially do a little step up in order to get credentialed at the level that is required for TEFCA, but it will be something they're familiar with, an account they already have established. All right, hit
Awesome.
me.
So question here from an attendee that they have heard a rumor that Epic is becoming a QHIN and may limit record sharing. Do you see this impacting interops or record retrieval?
So the rumor is correct. Epic is planning to become a QHIN. It's called Epic Nexus.
Well, they are. I mean, more than a rumor, you could go publicly look it up on the Sequoia Project website, of course. Epic is a QHIN today.
Right. They are
And
QHIN today.
go ahead. Yeah.
No, go ahead, Josh. What were you going to say?
So they're QHIN today, for sure, already. And then there's the other part of that question, and they limit record sharing, right? So there's a few different ways that I could like think about that question or respond to it. One is how just let me take the path of I'll provide you some information about it. So there's a documentation site that you can go to, and if you want to go through the trouble of becoming an IAS provider, just search TEFCA IAS Epic. There's a documentation site that will walk you through the exact requirements that Epic has. One of the requirements that I think is underspecified on that documentation is the geographic restriction for Epic responses. So Epic responses, you will only get a response back if you have an identity-proofed patient with an address that is physically close to the responding node. So what do I mean? We're only going to get back responses that are geographically bounded. That's a known public limitation, but that's actually, I think, underspecified. If they do specify it, credit to them, though, and I'll retract that. But that's some information about how it works.
And another question back to Clear and ID.me. Is there a way to pull patient data if they're not already using ID.me or Clear, or is getting set up on one of those mandatory to pull their data from a QHIN?
Angela, can I answer this one too? Because I just love this question a lot. Okay, I'll give the mic back. I really love this question. Patients 100% should have other means than a CSP of getting access to their data. Today, they do not. So today, we're facilitating, as an IAS provider, access to those records. It does require today going through an identity proofing vendor that is Cantera Initiative certified. There's 7 of them. There's 2 of those 7 that credibly right now can be used for TEFCA IAS due to technical reasons. In the future, and as a putting my Karen Alliance hat member on, because we're excited participants in everything the Karen Alliance does. I would expect from what I've heard in the public white papers that they've put out on this topic is that mobile driver's licenses should become at some point another kind of identity proofing solution here in the space. And I want to live in the future where this is not just 2 companies that you have to go to and go through. I want to live in the future where there are different means of providing proof. And hopefully some very patient empowering ones will appear. Right now, good news is that you can actually do the query. And we're going to be making it available for people in our mobile app for free to do, right? So that's I think still a huge win from where we are today.
And on the topic of those 2 companies, Clear and ID.me, can we use the information that comes back to fill out a patient profile or other information? In brackets, helps us with reducing onboarding, like type in insurance card, etc.
Not quite directly. If send me an email. Send me an email to josh@flexpa.com, and I'll dig like really, really in depth on that question with you.
All right. One note to add on the first question here. Perhaps you heard this in the rumors as well with regards to limiting or record access by Epic. One of the things that they require that's different from querying the network naturally, or not naturally, otherwise, is Epic does something called facilitated fire. So there are multiple steps in getting a document at the end of the queries to the QHINs. The first step is you go and you ask the network, like, do you have a patient that matches this patient that just went through clear or ID.me? The network say yes, and then you say, okay, which documents, which facilities and documents do you have? They send you that information, then you can retrieve the data. With Epic, it's a little bit different. It sort of stops after the patient match. And what they do after that is they provide you an endpoint that's very much like the provider patient access API route, if you guys are familiar with that. But you hit that endpoint, and it's a typical OAuth process where the patient has to go and log into that MyChart instance. So data still accessible, some road bumps, some hurdles along the way. Um, that's more than the other networks. All right, so going past this, we talked about why we multiplex on the CSP side. Why are we multiplexing on the QHIN side? So if anyone is familiar, we have historically put out a report on the payer patient access APIs, which are federally regulated by CMS 9115F. We want to bring the same level of transparency and reporting to TEFCA that we thus far haven't seen ourselves. So comparisons on patient match rates, document retrieval rates, whether or not certain strategies with the OIDC token perform better than others, whether certain matching strategies might perform better than the others, and really just explore these pathways, and then share our findings. So sharing with everyone else, and also hoping to learn from those who are accessing different networks.
Shout out to the Turquoise team, by the way, who put out a very great example of this work the other week on their price transparency reporting.
Yeah, big shout out to that team. They did a really good job. All right, so TEFCA, how it fits into the Flexpa platform is on the left here in network. It is one more source of data that we have built into the Flexpa network. On the consent side, you see clear and ID.me added with the other consent types. And then, as mentioned before, we support various standards for records.
Quick question before we hop on just on TEFCA land. What is the
Mhm.
benefit to having Commonwealth and No2 both?
Yeah, good question. So part of that is, let me go back here. Part of that is by going through two QHINs, and the QHINs have their own patient matching strategies. They may have their own um, idiosyncrasies, I guess, in terms of querying the rest of the network and getting documents back. We we primarily want to understand what some of those idiosyncrasies might be, and also shed light on any strategies or any methods that perform better or differently than others. That way, the industry itself, we can determine, like, where advantages are, where disadvantages are, but we want to shed a little bit more light to that and bring more real data to people's experiences with the network here. The Commonwealth versus No2 will not be visible to the patient. So the patient won't know, like, oh, Flex was querying No2 for me, or Flex was querying Commonwealth for me. That will be shielded and, for all intents and purposes, for now irrelevant to the patient. All right. So all these networks. Josh sort of alluded to this earlier, but how does it all come together in our consent flow for both patients and for developers? So FlexPlus Consent 2.0, we've sort of taken a step back and looked at all of our learnings from our consent SDK and consent flow from just pair APIs and brought in TEFCA, IDPs, etc., to build a sophisticated, a robust, yet still streamlined consent experience to the patient. So some of these screens might look familiar from the original demo that Josh played, but what you'll see here is in our Consent 2.0 onboarding flow, we provide a lot of steps and guidance to ensure that a user understands what they're about to go through. Because with identity verification, it requires a lot from a patient. It requires document uh, uh, verification, so either your passport or your driver's license. It requires a liveliness check, which is usually in the form of a self, so it can feel very high touch. We want to what's for this is. And in all the user testing that we've done, one of the aspects that has surprised me is that patients completely get this. Not only do they get it, but they expect it. Because if you're going to retrieve my data from a network, I sure as heck want to make sure that you're retrieving mine and the correct one. Moving through the first two steps here, in the fourth one, you can see that at the end of this flow, whether it's through payer APIs or through TEFCA, we retrieve your records from facilities that you've been to. Some of those facilities, like the top two here, might need more info, so that might be an epic flow. Or we might not have gotten your records from a particular facility you feel is important. So that's where we have a fallback flow to add a missing facility. This is where sort of the culmination of all these data sources in Flexpa's platform comes together in a way that feels like a singular experience to a patient, but is actually accessing multiple sources. All right.
Quick question on records
Yes.
retrieval. So how does TEFCA consent work for families that are trying to retrieve records on behalf of a loved one? Perhaps like a family caregiver that would be doing this.
Dependents are an emerging area for individual access services. So from an identity-based workflow, dependents won't have immediate access. You won't be able to access on behalf of another person. I should say this in a different way. You can't do that right now on TEFCA. So you can't, through the IAS path, you can't get that. In general, I would say you can't get that for a lot of patient access, but there are some standout examples when you can. And we've done a lot of work recently to try to figure out better ways of representing that information in FHIR. I think we just launched this, or we're about to this week. We launched a groups API that helps link multiple people that are associated with a single consenting person to into a FHIR API, if you will. So that's like an answer we deeply care about, but the complexity is sort of now depends on the part of the network that we're talking about. And in TEFCA IS right now, you can only do this for yourself directly. What we think will happen is that there will be a proliferation of ways of identity proofing that will enable those pathways at some point.
Okay. This last slide here just brings it all together and actually goes over details that Josh discussed in Q&A in the first demo, which is what does this mean for the developer's experience? There's a lot of inputs, and so what are the outputs too? All of these data sources, this patient experience, it's all still part of the same consent SDK. It's what we like to call an all-in-one consent SDK. So to a developer, it doesn't actually you still integrate Flexpa Consents SDK the same way you have before if you've played with our API, and it's all packaged in one. Identity proofing and QHIN network query, that's all managed by Flexpa, so none of that complexity is exposed to the developer. At the end of this whole process, you also get everything back in a single FHIR API. So everything is based on a FHIR resource, and you will receive that through a singular API, through Flexpa's API. And we've tried to bring everything into the most streamlined process possible for you as the developer, so that none of these various sources or complexities is surfaced to you. All right. So I will hand it back to talk about sort of wrapping up all these records together in a shareable manner.
So there was one more question there about the ID.me or Clear being hard to set up. Not familiar with the process. Just to quickly answer that, uh, you can do this if you file taxes with the IRS. You can go through the ID.me workflow there. Right now, as an immediate example, the specific IAL2 requirements are basically a selfie. Remote identity proofing is a selfie and one good piece of government issued ID, like a driver's license, for example. Um, it works really well on a phone, smartphone. It works on other platforms, but best on smartphone. Um, Soon, if you go to flexpa.com/app and register for the app distribution, you'll be able to try this out yourself for free in our app. So that's a quick answer there. Smart held links. So one of the other things that we released that I'm in particular excited about is the Smart Health Links API. So we were part of the pledgees to the Kill the Clipboard um, initiative as part of the CMS aligned networks and interoperability framework that was announced over the summer. Um, what is a smart health link? What is a smart health card is a good starting point because those are two different things. So a smart health card, in short, is a piece of verified healthcare data. So what does verified mean? It means that it is cryptographically signed in such a way that we can prove that it hasn't been changed, and we can prove that some other known person or people, organization, some key holder has issued it. So we can prove that it was validly issued by an issuer and that it hasn't changed. Um, so it's a portable piece of healthcare information that has some interesting trustworthy properties, right? Because if we know that some piece of healthcare data verifiably came from a certain institution or facility or practitioner, that could be a really useful data source. So smart health links are ways of transferring smart health cards that are just really big and other data. So it's not limited to just smart health cards. Smart health links can transport not just smart health cards, which are these verified records that I should also add appear as a QR code. So generally speaking, people interface with them as QR codes. They're transported physically in that way, presented. Um, they can be included in a smart health link, but other pieces of FHIR data can be included in a smart health link. And FHIR is flexible enough that it contains resources that allow you to base 64 just about anything you want and put it in there. So you can really transport really any piece of healthcare data through this framework. And it reached STU1, the interoperability a standard for trial use. Did I get that right? Maybe I have to edit the correct time here in the replay, or the correct reference there in the replay. But it became an official balloted standard in HL7 FHIR. So let me go through just a little bit of detail on it. I'll limit myself to just a couple minutes. But since I haven't really seen good public explanations of smart health links, I wanted to go a little bit in depth. So what does our API do? Our API makes it really easy to make these things because making them involves following a complicated specification with cryptographic like activity or workflows in it in a really precise way. So we make it easy to do through an HTTP interface, and we solve a host of problems around them. But how do they work at a core level? Well, we take our API takes a blob, FHIR bundle. So you can send us any FHIR bundle. We will take that FHIR bundle and we will encrypt it using AES 256 GCM encryption according to the specification. And that will generate a key that can be used in the future to decrypt that encrypted bundle. So we generate that unique key. We generate a 32-byte encryption key just for that one link, for this one FHIR bundle sort of upload. Then we throw it away. If you don't trust us to throw it away, meaning we can't reuse it to read the data later, you can also bring your own keys. It's just a little bit more complicated on the setup of this. Instead of sending us the unencrypted data, you send us already encrypted data. So we do permit a bring your own keys approach. That's just some additional setup, but if you need it, we can do it. After we've encrypted this FHIR bundle, we generate a URL for it that this encrypted bundle can be accessed at. We do that on S3. So we do that in S3. This is a public link. This SHL prefixed link. And that SHL link, protocol link, contains a base64 encoded object that points to that S3 location and includes the encryption key. And if you have those two pieces of information, you can both retrieve the data and read it, but you need both. Otherwise, it's just a garbled mess, and we actually have no idea what's inside of it at all. At the very end of that process, a QR code is generated that represents that text link, that SHL link prefixed URL. And that is the thing that's presented in person. So I know that's a lot. There's only a few minutes for this. Were there any questions so far from that sort of technical background?
Related to this, are there still any security concerns with the use of the QR codes, like potentially bad actors sharing fake smart health links?
Sure. I don't know about fake smart health links because in that case, we're just reading the data. And so like it depends on the context and what is fakeable here, right? Because these are cryptographically, a smart health card component, at least, of a smart health link is a cryptographically verified piece of data. So there is some provenance to it that you can trust that it was issued by a person and trust that it hasn't been changed. So it has some like really nice properties when it comes to the provisioning of like, why can't I just show up with some other dummy? I could change my referral, right? Or I could change my prescription or something like this. Like, can't do that. There are some security concerns that the spec deals with that I think really well. One is, well, if I just show someone this QR code, you're saying to me, anyone can just get, like, I screenshot it and then I've got those records forever? That doesn't seem great. And the spec actually deals with this in two ways. So a few ways, but I'll highlight two. One is passcodes. So you can create the smart health link, and our API lets you do this with a passcode. That's one. And then we automatically delete it if there are 3 unsuccessful passcode attempts at reading the data at the end. Because in the passcode case, we can't just host it on S3. It's still hosted on S3, but we have to count the attempts at reading it. And so you actually read it from through our API at that point, but again, in an encrypted way. So the passcodes, and then we also support TTLs. So you can have a really short-lived TTL on the smart health link. Afterwards, automatically cannot be read, permanently deleted. And so together, those are two nice security features over what is essentially a bearer credential. If I have it, that's enough to like use it, right? So the QR code in the spec has those two interesting properties. And also the QR code is only one like storage format. It doesn't have to be a QR code.
Awesome. And just quickly on the other side of the equation, so who would actually be scanning it, and how does it get decrypted and end up in a provider's EHR, as an example?
So if you go to flexpa.com/docs and click on smart health links, the next part of the diagram on that page, this is actually from that page, has the answer to that question in a really comprehensive way. So go there. Unfortunately, I can't answer it fully or as fully as I would want to, but we do in our documentation. I wanted to quickly show the implementation of this. Like this is all kind of nerdy and technical, but what does it actually look like at the end? And so we go back to our app, and inside of our app here, I can just hit that little QR code at the top, and up comes Smart Health Link. And that Smart Health Link contains the records, the claims records that we used in our example previously. And this is really flexible, so it supports any FHIR bundle. It could be an IPS, it could be just US Core, US CDI resources, it could be a document reference. It's flexible. It's also flexible to patterns where we want the patient, of course, to choose the information that's being shared in the Smart Health Link. So as an API, it's super flexible and can accommodate all of those workflows. And this is a working Smart Health Link. So it can be scanned. It uses the prefix URL here. So it uses a little Smart Health Card reader or viewer that we're displaying. Apologies, it doesn't look great. It's open source stuff, forked from open source stuff, so it's not perfect, but it represents and demonstrates the capability that if we scan this right now, it will show you that you can access this record. The last part of that question, though, as well on how would this work in practice, that's something that we're trying to figure out with industry right now as part of the CMS Aligned network is the answer to this question, because one of the public things that CMS has said that they want to do is promote the use of smart health links and smart health card workflows where the patient is providing this data up front. We do have a demo of that in the video that we played just at the beginning of this with Innovator. So we will share some more about that publicly with them really soon, but it's in the demo, and we're sharing that with co-pledges tomorrow, actually. So more about that soon.
And just a really quick scenario for you, Josh. So let's say a bad actor would show up to a hospital. That bad actor has a fake smart health link. The hospital staff would then scan that fake health link, and then the hospital system would get infected. So does the smart health link spec provide any recommendations to avoid a similar scenario?
Well, there's a bunch of words in there that I don't know. It would really require me to interpret them. So, like the infected in particular, I don't really know quite what is meant by that. I think I addressed the fake question a little bit earlier. So, like, what kind of fake do we mean here? I think maybe let me ask myself a question that I think is the vibe of that question. Like, what are sure, there's data privacy risks here. What are the other risks, right? Like, what are the other risks that come with the usage of smart health links? Some of the guarantees are that are things that aren't risks that have been addressed by the specification explicitly are provenance, integrity, issuer truthfulness of data. Those are three really powerful properties in defeating fakes. What are the other risks in processing them? I would say like less of there's some sense in which this is a risk, but it's more about like just a basic problem. It's how do I take this data from a patient? How do I take it from the patient and then integrate it back into a chart? Or how do I integrate it into a healthcare workflow where this is actually going to really help? Right? Those are deeper, harder questions because it's fine to be able to solve like you've shown up with the API, FHIR data, blah, blah, blah. But like, how did that integrate into some downstream system? How did we use that? Right? And I think there's more risk from an information security perspective. The spec has some really nice properties that make it a trustworthy source of data transfer. And I think that the risks are greater in, being forced essentially to implement something like this without understanding it or taking advantage. Like really in the interoperability space, if it's just a mandate, that's kind of not enough. It has to be more than that. And so I think there's a lot of risk there, which is why we're amongst the first. This is leading edge cutting edge stuff to make a public API that's usable in this way. And we're excited to explore the use cases with folks.
And probably our last question, unless someone else has one, is SMART supposed to be a faster way to do record retrieval for providers than going through the health information network?
Okay, I'll take the bait on this one. We got to the end before I was like, I'll take a bait question a little bit, right? We are so like in what makes Flexpa is being patient first and patient centric and like being patients ourselves. So the world where patients are more empowered to do things and participate directly in decision making about healthcare services and like my health, just overall, period, full story, end of stop, like we are very, very happy to support, including if it challenges in a direct way um, other means of health information exchange that might be established and certainly valuable pathways, but figuring out a way that we can empower patients and deliver, I love the term sneaker net, develop an alternative network that allows people to carry information with them. Um, that's our bet, basically. That's the future that we want to live in. So yeah, I'd love to see this become a replacement or a challenger to health information exchange. We believe in that future.
Last super quick question. I know we're at time, but is there any way to get Epic records without using a portal?
From an IAS perspective right now, yes, but not directly from this technology stack. You could get an EHI export. So you could contact the healthcare institution directly and ask for your EHI export. That's a different process, but it is possible. There's a great talk from Josh Mandel from not last year's, but the year before Dev Days about his success and failure at trying to use that pathway. But that is a pathway. That's it. Thank you all.
Thanks, everyone.
We'll celebrate on our side. Successful event for us. Take care.
Thanks, everyone.